Sri Aurobindo Hospital in Indore, which is basically in the rural area. This is where we work and interact with patients on a regular basis. Who's a teenager and young adult? According to the Ministry of Youth Affairs annual report here 2015 and 16, the teenage group in India is 15 to 29 years. I would categorize it in further three categories: 15 to 19, 19 to 24, and 25 to 30 years, 29 years. In UK, the age group is 13 to 24 years, and in the US is 15 to 39 years. Youth bulge of India. 32% of our population is between the age group of 15 and 30 years, and according to the census data of 2011, it amounts to 378 million, which is more than the entire population of the United States. We have an annual cancer burden of 1 million people, out of which 1.5% of these are in the age group of TYAs. Estimated new cancer patients are between 80,000 to 1 lakh per year, but we cannot be sure of these numbers. This is according to the National Cancer Registry Program data of 2012. And 68% of our population lives in the rural area, and the cancer center that we work in is actually in the rural area, implications of which I will discuss in my further slides. This is the central India, Madhya Pradesh. We have a total population of 68 millions here. And in 2015, we had approximately 93,000 new cancer cases, out of which the TYA cancer was estimated as 7,600. I would like to mention here that the per capita income in this area is 70,000 rupees per year, and I am sure that the situation is similar in the other states too. Why treat TYAs differently? They are in the prime of their lives, full of hope, aspirations. Biologically, the cancer occurring in the TY age group are very sensitive to most therapies. But in addition, young patients can tolerate the most intensive care treatment. They're likely to respond and achieve long-term disease-free survival if treated completely. Recognition and care of cancer is a great challenge. Risk factors for the cancer in TYA are poorly understood, and the cancer which they suffer from are individually rare entities, and suffering is diverse. So the research is not possible, or rather very difficult, in the small numbers. This is our aspirational India. They are young, they are perceptive, aware, ambitious. They are there to crack the system. They just want to go and get there. And 50 million youngster or young and adult teenagers, they enter the job market every year. This is according to the US ASEA data in 2010. The survival probabilities in the age group of which is the patient less than 15 years is 80%. Patients above 40 years of age is 66%, and between the age of 15 and 39 years is 36%. We all know that pediatric cancer are a great success story, not only in the developed area, but also in the developing areas. TYA is a very important part of socio-economic growth. Therefore, it is a challenge for TYA cancer, as the success rate is only 36%. TYA life issues. Independence. As they become teenagers, they find independence from the parental control. But once they have cancer, they go back into their shell, and they have to depend on their parents for everything, thus losing their independence. A young adult is very, very aware of its body image during and after the treatment, especially hair fall sudden change of skin color, body loss of body weight, loss of body weight, and in some cases amputation. These are the issues which caregivers, doctors, and nurses should handle together. Peer relationships are very important for this group because they tend to trust their friends more than they trust their parents. The sexual development is not complete in the TYA. So, and the treatment and its consequences has major impact on perception of the sexuality and the fertility. In addition, there is a very poor recruitment in clinical trials and lack of access to care across the world. UK Teenage Cancer Trust, CanTeen Australia, and Teen Cancer America are developing efforts to improving the access of TYA in cancer care. And TyCan Foundation is now taking baby steps towards the improving awareness and access. Abandonment. We have a lot of cases of abandonment in our rural areas. Failure to start therapy and or failure to complete therapy due to a lot of reasons. Could be financial, could be, as Leanne and just now Doctor mentioned, that the kids are left at home in the villages and the siblings are there, so they don't have that much of time to come back for treatment. So once they have their chemotherapy, they go back, they just don't come back. So that's a lot of abandonment we find there. And then a significant problem in a young person's cancer. The pediatric and oncologists have taken a big stride in limiting abandonment, and we need to emulate their steps in TYAs. This is the abandonment chart in SAMES Indore where we work. If you notice, 2013, we had total TYA cases of 179, out of which almost 50% we had the abandonment. But it has come down tremendously. If you look at 2017, out of 126 patients, we have only 10 which have not come back. It is because we are supporting them financially, emotionally, taking care of a lot of their needs. How do we reduce their abandonment? We offer them financial support before the government aid arrives and after it is exhausted. We keep a record of the patient's telephone numbers and the caregivers. Although we do that, but still there is a lot of abandonment because they go home and they change their numbers and they don't pick up the phone, or they just switch off the phones, So sometimes it's very difficult to keep a track of patient. Then multidisciplinary team, advocacy with college, school, employers, education of caregivers, nurses, volunteers. I would like to mention here, coping with therapies here is a humongous task for us. We have to find the right doctors, the right counselors, so that they don't, normally what they do in the rural area is that there is a lot of counseling, negative counseling coming from the relatives, from friends, from neighbors about, as he mentioned, spiritual, all those things. But we have to help them to trust the doctors rather than a layman. This was the first allogenic bone marrow transplant done in Madhya Pradesh by our senior medical oncologist, Dr. Prakash Chitalkar, in December 2014. This is exactly after 30 days. He's flying a kite in the premises of the hospital, along with his sister who donated the bone marrow. I would also like to mention he's gone back to school and he has a small business of takeaway of momos and dumplings in the evening in one of the areas in Indore. This is a typical patient profile. A 17-year-old boy just passed his 12th standard board exams, develops a cancer, early sign of independence, now reverse, because he's gone back to the parental control. Okay? Parents take charge, and in most of the cases in rural area, we also find that parents don't like to disclose it to the child or a young adult that he's got cancer. So when he doesn't know what's happening to him, he's angry, he's depressed. So our work becomes more because we have to then counsel the child and take care of his depression also. because he doesn't know. He just resigns to his fate that I don't know what's happening to me. And that's why I say it's a humongous task for us to find the right doctors and the team of counselors so that we can cope with the therapies. I would like to acknowledge the support we have received from CanKids for educational programs in our national conferences. What are the needs of a teenager in 2017? First and foremost, in autonomy, at this crucial juncture of the life of a TYA, they are very poorly addressed in our country. Then there is the urban versus rural divide. A teenager here in Mumbai or in Delhi behaves or permitted to acquire his or her own space like any other teenager in the West. But when you go to the rural area, you find the teenager there more grounded in the family tradition. He doesn't have a right to chart his own routine or own thing of life. But one thing is very common now in India, across India I would say, for the teenage TYA group, irrespective of their socioeconomic status, and their needs can be summarized as roti, kapda, and Wi-Fi. As long as they are connected, they can exist. So age-appropriate care and the personalized approach as against the systematic one-size-fits-all seems to be the dominant need for this group of patients. Needs of a young adult. Number one is all of the above, which I have discussed before, but the others are, when I mentioned the age group from 19 to 24 and 24 to 29, they need companionship, job security, financial security, existential worries, address worries for spouse and child, address worries about parents. If they don't have job, if they think they have cancer, there are a lot of people in rural areas still think it's infectious disease. They don't let them sit together, they don't help them in anything, and this is a big task for us to counsel them and tell them that this is not true, this is not infectious. So for that age group we have this problem. Teenage and Young Adult Cancer Foundation came into existence in Indore in January 2016. Our mission is to enable every young person to get the best possible treatment for his cancer and to get on with his or her life's dream and aspiration. TYA Foundation is an alliance of healthcare professionals, survivors, volunteers, and caregivers who form a composite population, survivors of pediatric cancer and young persons with cancer. What are TYA needs? Awareness among physicians, surgeons, pediatricians, and gynecologists. The young cancer person, he needs his identity. He doesn't want to be treated just as a patient, as non-entity. He wants to be a person also. Reduce abandonment. How we reduce abandonment, I've already discussed, that we visit them, we keep a track of them, offer financial support, and wherever possible, we do involve TACAN volunteers nearby, wherever they are, because our volunteers also are in the different parts of Madhya Pradesh, so we contact them, and they go and of course talk to them. Since January 2016, we have 61 members of TACAN Foundation, out of which we have 47 oncologists, 6 caregivers, 4 survivors, 6 volunteers, 2 counselors, and 2 admit staff. This is our team at Indore. Now the remaining part of my presentation will be devoted to palliative care needs of a young and adult. Pain relief. We have talked so much about pain relief, and I think it is important to ask a TYA how the pain has affected his feelings, the daily activities, and the relationships. Relationship with his parents, with his friends, with his peers, everything. And to ascertain that what the patient's expectations are, because it's not easy to talk to them, because they go back into their shell. It's so difficult to even make them talk what they're thinking, what's going through their mind. It's a very, very difficult task. Okay? But then the rule is pain is what the patient says hurts. Okay? And a clinical examination is very essential, and for that again we have to make sure that they come to the clinics, they come to the hospital and talk to the doctors, and then because the patients use their own words for pain, such as hurt or feeling bad. Even if they're feeling bad about something, they think it's a pain. So it's very difficult for us to, as a doctors, it's very difficult for doctors to know actually that what is he feeling. But as a counselor, maybe we go and talk to them, bring them out of their shell, and probably they can talk to us. Okay, and it is difficult to ascertain the pain is due to the physical discomfort or hurt, because since they are not even told sometimes about their diagnosis or prognosis, it can be anxiety, it can be depression or confusion. Structure of palliative care for TYA. Normally, when a person is treated in a ward or in a hospital, and for palliative care, he is shifted into a place which is far away from where he was. He gets the sense of he just gets a sense of abandonment. So probably to reduce that sense of abandonment, maybe we can have the curative and palliative care together, so that he doesn't feel that he's now being sent away, so he's going to die probably. Okay? We try and get his friends from schools, colleges, wherever we can find, because he's probably fed up with his parents telling him what to do and what not to do. So if we can find a friend for him that he can talk to, probably he can be on Facebook or WhatsApp group. As I said, they have to be connected these days, and create a virtual network. And then music or discussion or just conversation. An emerging care, lessons from pediatric palliative care, I've heard so much. So it's an emerging care pathway, effective symptom relief and symptom explanations, composite pediatric and TYA palliative care unit. This I would like to ask, how many people think that we should have the pediatric and the TYA palliative care in one premises? Anyone? You think it's a good idea? Yeah, it is. I think so, because because it's not that the children and the TYA has to be in the same room. They could be two different rooms, but probably be together, so that integrity of the family, at least in the end. I conclude by saying teenagers and young adults are a distinct group of patients with unique needs. Palliative care integrated into age-appropriate approach. The efforts to address their problems has just begun in India with TICAN Foundation. More centers need to join multidisciplinary societal approach. Thank you very much.